All right, so let's get started. So my name is Melissa Perry, and I lead the marketing team at CoolLeaf. And today we're going to talk about a really important issue, which is burnout among healthcare professionals. So that's doctors, nurses, physicians assistants, and really all the other healthcare workers out there. And COVID has really accelerated the problem of burnout, but it's not a new problem. It's something that has been going on for a really long time. And it's also not an individual problem. It's not something that can really be fixed with more grit or more resilience, but it's really an entire workplace problem. But there are a few things that workplace leaders can do to address this within their organizations. And we're going to cover some of these strategies today. And Dr. Mark Greenawald is going to share some of his expertise around how organizations can really battle burnout within their teams. But before we get started, I wanted to share a quick introduction to what we do here at CoolLeaf. CoolLeaf's experience platform helps companies engage with, recognize, and reward their people. Using CoolLeaf, you can enable your employees to give shout outs to one another for things like living the core values or going above and beyond. CoolLeaf also includes special programming, including virtual events, which can bring your team together, challenges, and pulse surveys. So there's a lot of ways that you can use CoolLeaf to boost your organization's efforts around things like diversity and inclusion, health and wellness, or learning and development. And you can incentivize and reward all of those things. And the last thing I'll mention on CoolLeaf is that we have a rewards catalog that is really powerful and employees really love it. We have all kinds of cool prizes like gift cards, charity donations, and experiences, which is a really great way to just show your people that you care about them, and it's all fulfilled by CoolLeaf. I also want to call out that we have another webinar coming up on April 29th, and that's going to be on the topic of developing COVID policies for returning to work and helping to overcome vaccine hesitancy on your team. So I'll post the link to that webinar in the chat so you can go ahead and register for that if that's something that you're interested in learning more about. So Dr. Mark Greenawald, we're really excited to have him. He is a professor at the Virginia Tech Medical School and the medical director for the Carilion Clinic Institute for Leadership Effectiveness. And last year, he rolled out a great program called PeerRx Med Program, which is a peer support and professional growth program. And it's already helped out a ton of individuals and healthcare teams around the world. So he's going to share a little bit more about that later. But Dr. Greenawald, I'll let you go ahead and take it away.
Thank you so much, Melissa, and thank all of you who've chosen to invest an hour of your life energy in our time together today, and for those of you who are going to tune in later on the webinar as well. I just want to start out by asking a simple question, and it's a question that was posed to me one day while I was over at our local YMCA swimming. And it was the swimming instructor hanging out with a bunch of the youth, and the question that she asked was, why should you never swim alone? So I'll just pause and ask that question. Why should you never swim alone? And of course, there were the eager children who were standing around her, all raising their hand, all wanting to be the first to answer the question because they, of course, knew the answer. And the interesting thing is, as readily as they knew that answer, is often as hesitant as those who provide health care, those clinicians on the front lines of healthcare, don't necessarily practice that answer. Well, of course, the answer that you don't ever swim alone is because that could cause you to be in danger should you have any kind of struggle in the water. You could drown. And yet what we know is that there are many clinicians who are drowning right now in the context of their work. And as Melissa pointed out, this isn't a COVID thing. I'll show you in just a few moments. This was happening way before COVID. COVID has done nothing but accentuate that which was already awful. And so what I want us to spend our time doing is thinking about, in your role, what you can do to impact the local culture where you work as a leader, to make sure that not only is no one swimming alone, but that the folks are taken care of, and that you are advancing their well-being, because there's some science to how that can be done. And of course, we want to make sure, just like no one swims alone, no one should be caring alone. And yet, again, statistically, we know that that's the case. So the first question I'm going to pose to you, and I would invite you to go ahead and use the chat function. Melissa's going to be monitoring that, and she'll be able to interrupt if there are questions in there that she wants me to go ahead and address in real time. But the question is, what is your organization presently doing to create a deliberate professional culture of well-being? We're going to come back at the end of this talk and actually explore that more together. But I wanted to plant the seed early on, so as I'm going through some of what I'm going to be presenting with you, you have the opportunity to be truly reflecting on that, and not just give a pat answer or a quick reactive answer, but to really think, what is our organization presently doing to truly create a deliberate professional culture of well-being? It's no secret that healthcare is in crisis. And again, we were in crisis well before the COVID pandemic. The COVID pandemic has done nothing but worsen that. Well, here's the good news about crisis. In the Chinese symbolic language, crisis is made up of two word symbols. The first stands for danger, and the second for opportunity. And so even as we are in the midst of this danger right now, in terms of our cultures of well-being, we also have an incredible opportunity to advance them in ways that perhaps we wouldn't have thought about 1 year ago. Here's what we know. In 2017, this study was published, and it was the third of 3 studies that were done at 3-year intervals by a national group led by a man by the name of Tate Shenefeld, a physician now out in Stanford. And what they found over these 3 consecutive surveys is that the high burnout rate for physicians in this case, was over 40% that whole time. And in the most recent survey published in 2019 of 2017 data showed that the mean rate across all specialties was 44%. 44% of the healthcare workforce of physicians who were operating at a level of high burnout. Now, many have heard that statistic so much that they've almost become numb to it. But let me break that down for you a little bit more. Because if 44% of physicians are in this high rate of burnout, and again, we know that during COVID, that's gotten nothing but worse. Very likely it's well above 50% now, as it was in 2014 when they published some of their data. If that's the case now, what about those other 56%? It doesn't mean that they're doing well. Most of them are at best in what I like to call survival mode. Or when you ask them how they're doing, they'll say, I'm fine. But what they're really saying is, I'm fine. I don't want to talk about it. I just don't want to go there right now, because if I do, I just might start crying. I just might start getting angry. All those emotions that are living below the surface. And here's what we know as well, that burnout is just one manifestation of something larger called distress. This is a definition of distress that was published in that last paper by Shenefeld and his colleagues. He said it's multidimensional. Distress is many things. It's not stress. Remember, we're not talking about stress, which is normal for most of us, but we're talking about distress, that stress that is taking us to a negative place. It includes burnout, but also depression. It includes the inability to have work-life integration. It includes professional dissatisfaction and fatigue, ongoing fatigue. Here's what we also know, is that our programming in healthcare is very unique. The culture of physicians and other clinicians is that we don't talk about this. Our administrative colleagues, on the other hand, it's not that they don't talk about it, it's that they don't want to hear it. They don't want to hear it because, it's not that they don't want to hear it because they somehow have an agenda that says we're in denial. They don't want to hear it because if you truly stopped and thought about 50% of your workforce in healthcare being at a place of burnout, it would be distressing to no end. And so being able to just say, what I know is that people are still showing up for work. They're still working hard is sometimes enough. And I've heard those same statements from many administrators. And then finally, our patients and payers, they're blind to this, because if they weren't blind to it, imagine the pushback that we'd be getting right now in healthcare. So that's our programming. Let's take our programming deeper from a physician perspective. Again, when I say physician, I'm talking about all those frontline clinicians. The data is different. We have a lot of data around physicians, less data around physician assistants and nurse practitioners. There's some data around nurses as well in terms of burnout. What we know is that none of those professions is doing well right now. This was a study that was published in January of this year by the folks at Medscape. And the title says it all, Death by 1,000 Cuts. And that's exactly what seems to be happening right now when it comes to a lot of this idea of distress in healthcare. Let's take a little bit closer look at what they found in this study. First of all, how do physicians cope with burnout? 48% by exercise, talking with family members. But here's the most fascinating thing, this third item here, isolate myself from others, 43%. Almost half, their answer to cope with burnout is to push others away rather than reaching out for help. I'm going to dig a little bit deeper in this because it is very telling in terms of the culture that we're trying to lift up as we start to think about how do we begin to address this whole crisis around distress and burnout. So they ask another question. Have you ever felt suicidal or attempted suicide? 13% of the physicians who responded said, yes, I've had thoughts of suicide, but have not attempted. 1% said, yes, I've attempted suicide. 1%. Now, again, you can say 1% doesn't sound that big, but if you stop and think about, my own organization has over 700 physicians. So that means 7 of them statistically have attempted suicide. And that means well over 70 of them have had thoughts of suicide but have not attempted. Very humbling when you think about what about this thing called burnout and what are the implications of this really. So they went a little bit further and they said, who did you tell about your thoughts of suicide? Number 1 answers, a friend or colleague, and just over a third, good. None of the above, in just over a third. So once again, you see that pattern of distress and then isolation, distress and isolation. Went on to ask another question. Does your workplace offer a program to reduce stress and or burnout? About a third said yes. Almost half said no. And they went one step further. How likely are you to participate in the program if they did have it? And almost half said very unlikely to do so. This is once again the culture that healthcare has created, and that's on physicians in many cases, in terms of our ability to reach out and ask for help when we need it. So what we're really experiencing right now is a distress 911. You think about burnout, there's a lot of talk now with COVID about PTSD, much talk about this concept of moral distress and moral injury, that idea that there is no right answer. No matter what I do, I'm going to be causing distress, or distress will happen. Compassion fatigue, I got nothing left in the tank. Decision fatigue, there's so much coming at me that I'm almost paralyzed to be able to make thoughtful decisions about patient care. Depression and anxiety, and then 3 that have been added specifically during COVID and have come more to the forefront to cause even more distress, and that be political polarization, social unrest, and then economic uncertainty. And when you add all those up, you think, where does that leave many physicians? Is these kinds of unexpressed emotions. Hopelessness, anger, fear, helplessness, sadness, weariness, demoralization, shame, guilt, loneliness. Loneliness. Here's a quote from Vivek Murthy, who's a former Surgeon General and is now once again the Surgeon General nominee. And he said, despite living in the most technologically connected age in human development, people in this country are isolated and alone. The percentage of Americans who report being lonely, 40%, has doubled in a generation. Now, Sean Acor, who's a researcher and a psychologist, took it one step further. He said, graduate degree holders reported higher levels of loneliness and less workplace support than respondents who had only completed undergraduate or high school degrees. And then he took it home. Professional degrees, particularly law and medicine, loneliest by far, 25% lonelier than bachelor's degrees and 20% lonelier than PhDs. So what you have then is the perfect storm in terms of what's going on right now in healthcare. Social distancing has really become disconnection. Disconnection from ourselves, disconnection from our profession, disconnection from each other, and disconnection, sadly, from our patients. Matthew Lieberman says that being socially connected is our brain's lifelong passion, baked into our operating system. It is how we are wired. And so what can we do about it? There are many interventions to reduce burnout, none more important, in the opinion of Mark and Frederick Southwick, two psychiatrists, than addressing the fundamental human need to belong. I want to pause for a second and once again ask the question, what is your organization presently doing to create a deliberate professional culture, not now just of well-being, but of connection? So I'm going to pause for a moment there, Melissa, and just check and see if there's anything that showed up in the chat that we want to address.
I don't think we have anything yet, but
Great. Okay, that's fine. I just wanted to make sure. Want to invite people once again to go ahead and bring your thoughts into that. Let me go on and talk a little bit more then about culture, and we'll come back and we'll have time for discussion at the end. There are only two kinds of culture, in my view, when it comes to any kind of organization. There are cultures by design, and there are cultures by default. And if you don't know which one yours is, you have a culture by default. Now, that doesn't mean that you don't have a very effective culture. What it means is if your culture, for whatever reason, starts to go south, if your culture starts to struggle for any reason, you have no compass to do some kind of realignment. You have no compass to do some reorientation, to do some recalibration. And so what does a culture by design look like? Well, we're going to explore that a little bit together. How do you create a connecting culture? John Fry, who was one of the grandparents, if you will, of family medicine, says this. He says, not valuing time with other physicians or allowing for informal conversation leads to a soulless efficiency and professional isolation that drains physicians of our ability to help ourselves, to help each other, and perhaps most importantly, and most tragically, to help our patients. So what is this thing called culture? Culture is the way a group thinks, the way a group acts, and the way a group interacts. The best way to understand a culture is to ask someone who is new to your organization what your organizational culture is like, because when you're swimming in the middle of culture, often you are very unaware of what cultures are really like. But every organization has them. And many organizations are totally unaware of what they really are, sometimes because they have a culture of aspiration. And so the culture becomes people saying all the right things and people talking about all the correct answers, but underneath the surface, things aren't necessarily that way at all. What we also know about culture is that culture eats strategy for breakfast. Organizations love to talk about strategy. We do it at mine, and it's a good thing. Strategy is wonderful. But if part of your strategy is not actually addressing and understanding your culture, your strategy will have a very, very great struggle to get anywhere. So we want to take a few moments to do a case study in culture. And that culture is yours. I want you to think about a few things as we go through some questions together. And what I'm going to do is I'm going to be putting these questions up and just allowing you, if you have a sheet of paper, maybe writing down the answers, just 1 through 6, and just write your answer, because at the end, Melissa is going to come back and she's going to put up a poll. This will be an anonymous poll, but just a chance for us to get a sense of the pulse of this particular group today. So your professional culture presently and your organizational culture ideally, because likely there's a gap between the two. And what I want to do is give you 6 ideas about what you could do today to help close that gap. And they're based on 6 behaviors that you could start doing, and that you could start modeling, and that you could start spreading throughout your organization. I call this being a 5 stars connection culture. And STARS is an acronym that I created that stands for service, teamwork, attitude, reflection, renewal, and self-care. So let's break that down a little bit and take a look at some samples of some questions that could help begin to calibrate your culture around the stars. I want to get personal, so I'm going to ask you, in the last week, on the continuum from never to daily, in the last week, I'm assuming you've been at work in the last week. If not, think about the last week where you were present in your organization. Service. I recognized in the last week, I recognized my teammates for their good work. Teammates being however you would want to define that. I recognized them, and recognition, however you would want to define that. Now again, you stop and think about this. Often when we talk about service, we talk about service to patients. And that's very, very important. And yet, there's the aspect of service to teammates, service to care teams, that will then spill over and will really translate to what kind of service we provide our patients. So I like to say, you will never be able to provide 5 out of 5 care, which is the standard that many national patient engagement surveys use. Clinicians will never be able to provide 5 out of 5 care if they're operating or feeling like a 1 or 2 out of 5 clinician or care team. So how do we make sure that we're uplifting our teams and serving them? Teamwork. I checked in with my teammates this week and know about their joys and their struggles. Never to daily. Now again, stop and think about this. At least in my profession, in family medicine, we have huddles, care team huddles every day to plan for the day. Those huddles are very operational. They talk about who's coming in that day, what we need to do, what kind of preparation we need to make. And often we will be blind to the fact that people are bringing incredible burdens to work every day that are impacting their ability to function at the highest level. And we don't even have the opportunity to support them because we don't even know what it is that they're struggling with. So how do we create a culture where that becomes natural, where people, we don't even have to ask, people will volunteer. Hey, just want to let you know that today, here's something that I'm bringing with me. And sometimes those things are good and uplifting, but sometimes they're not. It can be something as simple as a sick child or a sick family member. But those things become important in terms of making sure we're taking care of our teams. And that's the only way we're going to have a 5 stars culture. How about attitude? I helped to create a positive and encouraging team attitude this week. Again, by however you would define creating that. Never to daily. There's some who say attitude is everything. And while I wouldn't necessarily go that far, what I would say is attitude is a whole lot. And so how do we create cultures in which we are regularly making sure that we're not only checking in around people's attitudes, but we're helping to enhance them? And this is not about just being positive. People pretending that they're being positive while they're struggling on the inside is a culture by default, or a culture accidentally by design, because that's not really ultimately what we want. We want people to modulate their behavior, absolutely. But we also want to make sure that people are happy and positive because frankly, they really are. They love what they do. They love who they do it with. That's the kind of culture that we want to create. How about reflection? I regularly connected with those things that have meaning in my work. From daily to never over the past week. Reflection becomes an important thing. One of the things that's happened during COVID, I fear, is that we've lost that check-in. While we sometimes talk about it a lot, people are in such survival mode that we don't stop and we don't say, let's think for a moment about what's going on. And I'm not talking about the rhetoric around being heroes. I'm talking about the work that we did way before anybody talked about heroism. Every day, things that matter greatly to human life. What are we doing to check in, to affirm each other around that, to lift each other around that, to appreciate that? Renewal. I took time to celebrate our successes. Again, however you would define celebrate. We're not talking about parties here. We're not talking about recognition events. We're talking about those little touches that make the difference when we notice something went well. And then we name that and we stop and celebrate that and recognize that. That's culture. How did you do this week with that? From never to daily. And then finally, self-care. I took time for stress reduction and relaxation. When I talk about the stars with some of my medical colleagues, some of my physician colleagues, this one often brings eye rolls because they say, we don't have time for this right now, particularly in the times of COVID. And what I say back is, you don't have time not to do this right now, because the cumulative effect of stress and distress will be wearing your teams down. It is wearing your teams down if you're not taking direct action to try to address it. So Melissa, I want to pause there and go ahead and do the poll. And let's just see where those who are here with us live today, how they did with that. So if you would go ahead, again, this is all anonymous. It just gives us a chance to check the pulse of the group and see where folks are. So I recognize my teammates for their good work over the past week. And then I checked in with my teammates. So go ahead and take a moment to answer those. The whole way down, you'll see that you can scroll down on the right to all 6 questions. I'm going to do it as well, just yeah. And Melissa, just let me know when we have a decent number of responses.
Okay, yeah, we're almost there. We're at like 70%. So
all right, very nice.
Wait a few more seconds.
Okay. Now it's getting suspenseful.
All right, I'm gonna go ahead and end the poll so we can see the answers here. 1 second.
Okay.
Right. Are you guys able to see are you seeing the results now?
Again, you'll have to scroll down to be able to see all of them, but it looks like that in general, often seems to be the most, sometimes to often, it looks like, seems to be the most common response. And what that tells me is we have opportunity. You have opportunity in your culture, because if you stop back and just reflect on those six questions, and at the end of my talk, there'll be some references, and one reference to a paper that I published 2 years ago that has that whole survey in it. It's something that you can go back and look at and say, really, if I think about our culture, those would be attributes of our culture that would be important to do every day. If I really want to make sure that we're operating at the level that I want my healthcare culture to be operating on, if I'm a patient, then those are the kinds of things that we want to do every day. If we want to create a deliberate 5 out of 5 culture, those are the kinds of things that we want to be doing every day. So what about this connection culture? As we talked about earlier, connection is vital to this, and isolation is the default mode of many physicians in healthcare. So how do we then create a connection culture? Well, the good news is there's a secret weapon. The secret weapon is relationships. And how do you foster the relationships between your clinicians, between your nurses, between your advanced care practitioners? How do you create this kind of culture that we want to have? I like to think about this as a layered approach to clinician in-reach. And again, when I think about clinicians, talking about physicians, physician assistants, nurse practitioners, nurses, any others who you have who are operating at the front lines of clinical care. So if we think about this in-reach approach, and we think about 42% plus burnout rate, and we think about 13% of physicians who've thought about suicide at some point, the first step in this has to be that they know if their life is crashing, there's a place they can reach out to. They know how to access a crisis hotline. And that shouldn't be something that we're apologetic about. Again, putting it out there doesn't suggest that people are, because they see it, are going to start thinking about those things. We know that's not the case. But we want to create a culture that's safe to be able to say, I need help. That does not shame people when they reach out. And in many cases, in many healthcare cultures right now, that's the case, that people feel ashamed. And that's one of the reasons that they don't reach out for help. So crisis hotline, very important. On the second level then, other services, other mental health services, like the employee assistance program, if that's something you have in your organization. The second victim program, which is a program for people who have clinicians who've been part of a bad outcome or some other traumatic event. The first victim being the patient and the family of whatever unfortunate circumstance happened, but then the second victim being those who were involved in that care. And then other mental health resources. Now here's the important thing to understand when it comes to this from a physician perspective. While these resources are wonderful resources, the culture of physicians in healthcare is that they will not access them. Study after study has shown that many physicians don't trust the EAP program within organizations. They don't feel that it's confidential enough, even though we know that structures have been put in place to make it that way. There's other reasons as well from a physician culture, but it's something for those of you who are watching this webinar to understand that if that's the only choice that you're offering, you may be missing a lot of people who need help but aren't seeking it. And then there's peer support. There's peer support groups. I'll give you some references to those in just a moment. Peer one-on-one support. This is peer one-on-one support for people to reach out if they are feeling distressed, that there is a colleague that they can reach out to in a formally structured way. And then healthcare resources, making sure that all of those healthcare providers have access and the opportunity to have their own healthcare provider. And then in the next layer is peer connection. Talk about that again in just a moment. And social gatherings, other wellness resources. A lot of organizations mistake their wellness program for these well-being initiatives for clinician in-reach. A lot of wellness programs, which are wonderful, are really much more about good nutrition, physical exercise, getting sleep, all things that are essential, but they don't address some of the deeper needs and some of the cultural issues that are causing distress for many. And then finally, they're organizing groups that are bringing all this together. In many organizations, that's a well-being committee. Sometimes organizations now have a chief leader, some kind of clinician leadership, such as a chief wellness officer or a CWO or somebody else who is taking the lead to make sure we're addressing these things. Talked about professional gathering spots for clinicians, and there are many online forums that are out there. They're finding meaning in medicine discussion groups, and again, there are links for all of these, and Melissa can get you more information about those. Compass groups, Mayo Clinic has published about this. Compass standing for Colleagues Meeting to Promote and Sustain Satisfaction. These are dinner groups where people just get together, physicians just get together to talk together, and the tab is on the organization, and they just get together to really share life together. Ballant groups, which is another group that allows clinicians to process some of what it's like to be doctoring. And then there's the doctor's lounge. There's the real doctor's lounge. In many organizations that has disappeared or has become much less used. And then there are virtual doctor's lounges that you can set up and that others can set up in order to allow physicians a place to gather. And then There's PRX. PRX is a program, as Melissa pointed out at the beginning, that I started back in February of last year, pre-COVID. We had been actually piloting this program for a year prior to that. And the intention was never that it would have anything to do with COVID, because COVID didn't exist at that time. But we actually rolled out the website in February, and then 2 weeks later, the COVID was considered a pandemic. And PRX became something that was very, very timely and very serendipitous in many ways. And the underlying underlying point of PRX is what I talked about at the beginning. No one cares alone. How do we make sure that we're creating a deliberate connecting culture so that clinicians feel safe reaching out to each other to share this journey together? The actual program that I designed has some very simple parts to it. There's a check-in that happens once a week, and what I say is as little as 90 seconds by text, email, or phone. And there's a weekly email that comes out from me as a nudge and a blog that provides some extra information around whatever the theme is for that week. And then there's a once a month check-in for up to 90 minutes, but it can be for as little as 9 minutes that is preferably live, but another way for clinicians to check in. And then there's what I call the 90 and 90, 90 minutes every 90 days for some recalibration and some check-in as well. And the program that I've created around this is called PRX 90. And PRX 90, basically in 90 seconds, it's a check-in. How are you doing? How can I help and support and encourage you? Very simple, very powerful. Monthly check-ins. How you doing? What's going well? What's not going well? What are you struggling with? How can I help, support, and encourage you? And then quarterly check-ins that look back over the last 90 days and look ahead. Say, how are you living out your values? How are you connecting with meaning? What are your goals? What are your dreams? When do you have your next vacation or adventure? All things that are often neglected in the context of culture by default, where many physicians don't take more than a week, if that, of vacation in a year. So I want to pause as we come to a close of the formal presentation and just ask again, what might you do to create a more deliberate professional culture of well-being and culture of connection in your organization? Before we open up to discussion, I just want to provide you a few take-home things, and have designed this around listening, encouraging, and fostering this deliberate culture of connection, this deliberate culture by design. First of all, as leaders, it's important that you're actively seeking feedback, that you're not doing it passively. You're not saying, come to me with feedback, but you're going out, you're rounding, you're asking people, what's it like? Not only to be doing healthcare right now, but what's it like to be working here right now? And if you can create a safe space for people to answer those questions, they'll give you honest answers. And just be prepared that it may not all be wonderful, and that's okay. Encouraging. How do we make sure that we're encouraging health and well-being, including both mental and emotional health as well as physical health? And what's that looking like in your organization? Then finally, how do we foster stronger connections through programs like PRX, through recognition programs like CoolLeaf? How do we do those things as well? So I want to pause now, and we've left lots of time because Melissa and I were hoping that we could engage you in some dialogue around just what's stuck for you today, what stood out for you, what were some highlights, what were some insights perhaps, what are some things that you feel differently about in terms of taking action, and most importantly, what are some questions you might have that we can discuss together right now. So Melissa, I'm going to hand the mic off to you, and let's see what's come up so far.
Yeah, and thank you so much for sharing all of that information, Dr. Greenawald. That was really illuminating a lot of really powerful things, and I think everyone here is going to be able to take what you said and really put some of those things into place within their own organizations. So thank you. And I wanted to share a couple of my thoughts before we go into some questions. Some things that stood out to me as being really powerful from what you said. So, and I read recently that there's been new research that around like the sense of belonging, which was something that you spoke to, which is really important. And that the main reason that employees feel the greatest sense of belonging is just when their coworkers are asking them how they're doing. So yeah. Like that simple thing of checking in is just so powerful and so important, and can be often overlooked.
It's huge, Melissa. It's huge. People want to be part of something bigger than themselves. and it's a great demonstration of that.
Hmm. Yeah, absolutely. I also loved what you said about listening. That's just really critical. And you shared an image earlier in the presentation today with the monkey covering their ears. I think that's unfortunately a common mindset, not
Yeah.
wanting to hear about burnout. But it has such negative impacts that not listening to it is really harmful.
Yeah, and Melissa, just that idea, and again, that's in no way that's just our programming. Those are our temptations when it comes to this kind of culture that we're in the midst of, and so part of overcoming that temptation of really not wanting to hear it is to actually become curious. And to go one step deeper. So when people say, things just aren't that great around here, rather than getting defensive right away, or challenging them, which will shut them up in general, get curious and just say, well, tell me more about that. What is going well here? And then what's not going well from your perspective? And when you frame it that way, you'll discover that there are some things going well for folks, and there's some things that could be addressed very easily once you understand what's really going on for folks.
Hmm. Yeah, I like that. That's great advice. And we also had some feedback from one of the attendees that I thought was really great, saying that one of the major challenges in the medical world is that time is money.
Mhm.
And there's just so much pressure to fill every minute with helping patients that these things are just not supported by the organization. But it really needs to start with leadership. And that was Hannah who shared, or Hanny, sorry, who shared that. So thank you
Thanks.
for sharing that.
So Hanny, I love that. Thank you for sharing that as well. And here's something to consider, and that is that when we look at the physician culture, and again, I look at the physician culture, and then I look at the larger organizational culture of which physicians are part. Time is money, and yet if you do a time study of physicians who again are the billable, they're the ones submitting the bills in an organization. They're in many ways the economic generator of what's happening in healthcare organizations. There's a lot of time that they're using that from a billable perspective is incredibly wasted time. We talk about working to license. I think about my day in clinic yesterday and how much of what I did could have been done by somebody else who is not having the kind of salary that I have, not having the kind of income that I have, and yet could have set me up to be able to do more work that was actually billable work. And so, yes, time is money, and yet many organizations are very inefficient when it comes to how do we optimize that, while at the same time recognizing that we're talking about humans here. We're not talking about assembly lines. We're talking about humans both in terms of our workers, we're talking about humans in terms of our patients as well. So how do we make sure that we don't lose that meaning and become soulless in thinking that it's only about money, rather than money, of course, is part of why we do what we do, and we need money in order to be able to do what we do. And yet it's really about humans. It's really about health and well-being and disease, and making sure that we're connecting in on that as well, because that will inspire people to work way harder to be able to earn the money if they know they're doing it for a deeper reason than just, I'm just having a job.
Mhm. Yeah, yeah, that's so true. Um, and then we have another question here. This is from Deborah, and she says, how can this approach be applied to the nursing level, where there's very little budget or time to make that shift? And she says that inpatient nurses in particular are really struggling, and lounges have been taken away, and it's just a really hard time for them right now. So, Dr. Greenawald, what advice do you have there?
Oh, my heart bleeds for my nursing colleagues. Absolutely. And actually, I have a meeting this week with a woman who's a national leader in nursing to talk about what would it be like to take this PRX program and make it more formally addressing the needs of nurses. So I'm very excited about that. But let's talk about that for a moment. So in terms of the money that's involved, the PRX program it costs essentially nothing. I've created this program on a shoestring. And doing it costs very little. And so creating a connection culture takes somebody who's willing to be a leader and to be part of that, and to be able to say, let's organize this and to do it. And again, I offline, certainly Melissa can provide my email if anybody wants to reach out to me to talk more about how that might look for your particular organization. But But again, it's important. Our nurses here in my own organization hurting right now on the inpatient side. Many are looking to get out, and that's a tragedy because their hearts are in that work, and yet they're fried. And so how are we going to make sure as we start to hopefully come out of COVID and catch our breath again, how are we going to make sure that we are actually reaching out to nurses and acknowledging, first of all, one of the things I notice in many organizations is that we haven't really acknowledged, we haven't really named that there's a problem here. That people are struggling. Again, it's way easier to hold your hands over your ears and just say, we're going to soldier through this, everything's fine, rather than saying, we know things are hard right now. So let's get through this together. Let's connect with each other around this, and let's lift each other up and make it better. Knowing that, again, for the next 6 months at least, we're going to still be in it when it comes to COVID. And that's going to be very, very challenging. As well, again, I have a military background, and so knowing that even though this is not combat, I would never compare anything to combat. Combat and war are horrific, and yet we know that the conditions in some of our hospitals and emergency rooms right now are not great, and the decisions that are having to be made there are horrific when it comes to just what it means to say, who am I going to triage, and who are we going to take care of, sometimes with limited resources. And how are we then making sure that we're checking in with those folks? Because PTSD is going to be huge. It already is huge. How are we creating mental health resources to help take care of them? Those are things that we can do. And if we're not doing those, if we say we don't have the budget to do those, that becomes a real crisis within an organization to say, what do we really stand for at that point in time? So that becomes a real heart check and a real gut check around how do we prioritize the resources that we have? Because again, you lose nurses, you can't staff beds, you can't take care of patients. We know that. And so that formula is one that we have to make sure that we're addressing.
Dr. Greenawald, how would you suggest speaking to leadership in regards to this kind of thing, that this is an issue that needs to be addressed right now? How would you suggest speaking to that to leadership?
Yeah, it's a great question and a really challenging question. It's a question that I get asked regularly, and it's a question we grapple with here. We have an open dialogue with our own leadership here, and in many ways that's taken years of multiple engagements in order to make that happen. But I do think you have to name it, first of all, and just to say there's a problem here, and I encourage people to reference national data. The National Academy of Medicine, which is a very respected organization within healthcare, the American Hospital Association on the administrative side, very respected organization within healthcare. Those are two organizations that are talking about this. So referencing that and then being able to say, I've been reading about this, I've been learning about this, and I'm wondering how I can help, rather than just challenging and saying, what are we doing at our organization, which again will cause defensiveness a lot of times around leaders, saying, what can I do to help advance this culture of well-being in our own organization? I think that's a very, very powerful way to do it. It's amazing how many organizations, again, with data that's very much out there, are still struggling with this. And one of the temptations that happens in many organizations is what I call the culture of exceptionalism. I believe it happened early on in my own organization. We did our first well-being and burnout survey in 2016. And one of our motivations for doing it was because I believe we looked at the national data and said, this is not good. And my own sense as a clinician and leader was, it wasn't good in our own organization either. But there were a lot who said, well, that's not what we're seeing around here. Because if I have a mind's eye of what 56% burnout looks like, that's not what I imagine. That's not us. And so that's what I call organizational exceptionalism, which is that I see the national data and that's terrible, but we're different, we're better. And I want to believe, all organizations want to believe that. And my answer is prove it. So do your surveys and show, because if you are exceptional, then you need to figure out what you're doing and write a book and go on tour. And if you're not exceptional, then you need to be able to say, well, let's look at our own data. And now we have the impetus to do something about it because it is personal. It's not just national data. This is our data. These are our people now. And we really, as leaders, we shouldn't stand for that. We shouldn't look at that and say, it's okay to have a 50% burnout rate. In my own organization, we talk about our culture of safety when it comes to patient care. And we say even one is too many when it comes to any kind of bad outcome that involves patient safety. And my answer to them is, I absolutely agree with that. And if we're going to get to one being too many in terms of patient safety, then even one burned out clinician is too many, because that one burned out clinician is the one at risk for causing a patient safety event. So part of the other strategy that we've used here, and I believe is a national strategy, is to connect this work with your patient safety and in patient quality work. That saying, this is not just a poor physician's, too bad, they need to take care of themselves, but this is a quality and safety issue, reframes the conversation completely. And so we've done a good job here of beginning to tie this work more and more with our patient quality and safety work, and that's elevated the conversation. And then we have data that we can look at around it as well. Hope that was helpful.
Mm-hmm. Yeah, absolutely. I think that what you said about connecting it back to patient care is something that's really powerful for a lot of organizations, and things that a lot of organizations forget or aren't as mindful of. And I love what you said earlier in the presentation about you can't provide 5 out of 5 care if you're feeling a 1 or a 2.
Can't do it. The math doesn't add up. It just doesn't.
Mm-hmm. And what are some of the impacts that you've seen in healthcare organizations that have put some of these tactics into place, that are doing things like check-ins, surveying, and are building, a culture of connection? What are some of the results?
Yeah, and this is early in terms of really looking at data. We know that there's some data coming out of places like the Mayo Clinic that have shown that this literally and very tangibly impacts burnout rates, that they have seen their burnout rate decrease as they've started to increase these cultures of engagement. Again, the work is young. We've not done those surveys here at my own organization. That's just a bandwidth issue on my part in terms of being able to organize that kind of research to be able to do that formally. What we have seen in my own department, where we've done a little bit more of that research, is that as we've done InReach, our burnout rates have gone down. And so again, that is an important first step. Now, again, I want to caution people when it comes to looking at burnout rates. Remember, we talked about earlier that on the other side of burnout is this thing that I call survival. Survival is better than burnout, but survival is not your ultimate goal. Survival is not your ultimate destination. What I call thriving is your ultimate destination. Meaning, joy, those are the kinds of things and the kind of environment that you really want to create. So if you have a culture of survival, again, that's better than a culture of burnout, but you're one decision, one outcome away from folks being in distress and burnout again. So how do you move people up what I call the burnout to well-being continuum, or the burnout to thriving continuum? And then you have to keep on infusing these things. That's why the daily piece becomes important for things like the stars, because if you're not doing that daily, all of the forces are pushing people into distress. That's part of the culture of medicine. That's just part of the work that we do. It's emotionally and physically challenging, and it takes a toll. So how are we making sure every day we're incorporating opportunities for recovery? And that becomes part of the culture. And so, yeah, taking some time to very deliberately create structures will then begin to provide feedback. One of the other things to remember that I think we've learned here, in a very important lesson, is that in your organization are microcultures. Each of your clinical departments is a microculture. Each clinic is a microculture, but each clinical department has their own way of doing things, at least in our own organization, as I've seen around the country. So having a central group that's talking about this, and then having ambassadors who are opinion and thought leaders within individual departments be able to go back and translate that to individual departments, I believe is going to have more impact than thinking that you're going to have a one-size-fits-all organizational program that's going to touch everybody. And so keeping that in mind as you think about well-being and well-being interventions, I think is going to be essential for success. And we've seen that happen here. Now, unfortunately here, the uptake has been different across different departments. So we've seen some departments that are advancing faster up that continuum than others. But that's okay, we learn from that. We do rapid PDSA pilot interventions, and then we learn from that and spread those learnings to other departments to allow them to translate that into their culture as well. And as you start doing that more, and again, that's by design, you're going to start to see results of that. And people who will come to work to a place that they believe has meaning, and then your engagement scores will begin to go up as well.
Great. I think that's really important too, what you said about it's not really something that can be one and done. It has to be a continuous effort within the organization forever, essentially, if you want to have a culture of purpose. Do you have any? Sorry.
It's not an event.
Yeah.
And that's what happens, I think, in a lot of organizations is we create a program and then we have an event and then we have a rollout. And again, within a year that kind of dissipates. And again, that's cynically called flavor of the month. And we are not immune to that in healthcare, certainly. And so how do you make sure that that's not the case? Is, as you said, Melissa, it's got to be part of it's what you do. It's part of the culture. It's what you do every day. And that will last. That will last because it's not a gimmicky thing. It is something that is part of what you do all the time.
We have a couple minutes left, and I wanted to touch really quickly on, there was a question about destigmatizing mental health.
Yes.
So that is a major issue. But you mentioned people don't want to come forward. They're scared to, and it's a huge problem, not just in healthcare, but in a ton of different industries, but it's particularly important in healthcare. So what are some steps that leaders can take to destigmatize that mental health within their organizations?
Yeah, thank you for that question. It's a huge problem. And again, that has to do with both the culture of medicine and the culture of healthcare, because many people have been programmed to think we are the caregivers, not the care receivers. And so that becomes an either or proposition. And in many ways, in doing that, it really causes a decrease in our own humanity, which is a tragedy. So how do we do that? Well, an interesting phenomenon is now happening, at least within the physician world, and that's where some physician leaders, national leaders, are starting to come out and share their own stories of their own struggles with mental health. That happened recently for somebody who was a leader of the ACGME, which is the accrediting body for residency programs, where he came out and talked about his depression that he had had over many years of his career through the times when he was a dean of 2 medical schools. That's wonderful because that starts to open up the conversation. It's tragic because it demonstrates that for all those years, even leaders like himself were unable or unwilling to share that because of the stigma around mental health. And he's a psychiatrist. But beginning to talk about that, having leaders talk about that. I have my own story that I've shared in many of my talks and webinars of my own struggle with mental health issues, in this case around likely burnout, likely some PTSD, and how reaching out to a therapist didn't literally save my life, but figuratively gave me my life back. And so I take every opportunity I can to talk about that, talking about in your own organizations, what resources are available. If you have people, leaders in particular, who are willing to talk about that. Again, microcultures are huge and opinion leaders are huge. And if you can have folks who are opinion leaders within different departments who begin to destigmatize it, that becomes much more powerful than the general culture of medicine. And we've seen that happen here. And I have physicians reaching out all the time to me now because I've shared my story, asking, how can I reach out for help? Well, here's some concerns I have. I don't trust the system. How can I do this in an anonymous way? And so again, we're trying to create that culture here. It's not easy. It's not going to happen overnight. But as I mentioned earlier, making sure that those emergency numbers are available as well. Sadly, we don't know who uses those numbers, but confidently, I know that some people do because the statistics say that many people are thinking about hurting themselves, thinking about suicide, thinking about how distraught they are. And so making sure that they know there's something that will help to provide them the opportunity to reach out that's safe and that's anonymous becomes really, really important. And so again, local culture becomes important, and as much as possible talking about it and destigmatizing it and demystifying it in many ways. And using national data, again, that provides an opportunity for people to just say, wow, if everybody else is feeling that way, maybe it's not so bad that I feel this way as well. And so using national data in that way, in many ways, depersonalizes it for people and gives them permission to say, I'm not alone in this.
Thank you. That is all so powerful. I think we really learned a lot today here. I certainly did. So thank you so much, Dr. Greenawald. And I will share Dr. Greenawald's info, his email, and in the follow-up email that we're going to send out later today. And we'll also have these slides available for download. So if you'd like to access any of these links, we'll have them there for you. I've looked through a couple of these, and there's a lot of great material here. And then after the webinar, you'll be taken to a quick poll. So we'd love to hear your feedback And again, if you have any follow-up questions, you can also put that in the survey that you're going to be brought to in a second. But thank you all. We really appreciate you joining us. This has been a great session, and thanks for sharing your feedback and your thoughts with us.
I really just want to take a moment, Melissa, to thank you and to thank everybody again who took some time today to attend this. I hope you're taking something really helpful away. And as Melissa said, she will be able to provide my contact information if anybody would like to reach out to me after the webinar is over.
All right. Thanks, everyone. Have a great day.
Take care now, everybody.
Bye.